Elizabeth Saywick from UBC in Vancouver. Really great presentations, very thought-provoking, and especially after thinking about sort of what was presented this morning as well. So the question I have is how does thinking about sensation-seeking and impulsivity and sort of personality disorders intersect with some of the social determinants of health work around trauma or stress and its role in addiction or problem substance use? And specifically, Patricia, if you could speak to that.
Okay, so as a trauma specialist and researcher and clinician, it's a topic that's on my mind, and it's clearly something that we need to begin to incorporate. So what we do know from these trials, for example, is that those who are victimized through their peers are at much higher risk for substance use. And in fact, a quick peek at our findings are that those who are more victimized in our sample respond better to these interventions. So, it might be that they're just, at elevated risk and more emotionally labile, but that it's still through targeting their personality and their general temperament that you're going to produce this kind of effect. So we still have to explore it. There will be some bullying data that will come out of this trial, and they look very interesting with similar herd effects, but with some personality-specific effects. So there are perpetrators and there are victims within this sample, and the interventions have different effects for different personality profiles. So.
Thank you. Yes, Kendall, Dr. Ho.
Hi, Kendall Ho from UBC. Thank you very much. A great conversation and presentation. Really enjoyed the whole day too and thinking about it. And one of the things I was thinking about is what's the leverage of social media in doing this? Great constructs in terms of, for example, personalities and management and epigenetics. Also understanding environment and the opportunity for the young people, especially in, I was just working at Frosh Week last week in Merchants Department, a lot of people coming in drunk, to be able to use social media to, number one, understand the different stressors that they may have or the type of personalities there are, and also as interventions, how that might be able to be supplemental to the type of therapies that are there. There's a lot of discussion about online identifying personality through Facebook and Twitters. The discussion about, for example, using Google data to analyze the emotions of people through natural language processing, for example. What are your thoughts about leveraging social media not only to capture the epigenetics, the genetics, the behavior, the constructs, but also really start to capture the environment and the social aspect of it and digitize it so we can understand and research on that area? Thanks.
Patricia.
So something else that will come out of this trial is that we've assessed the social network. Because we assess the whole grade, we're then able to follow every child within the trial, and we've asked them about their top 5 friends in the school. And so what that means is we can create a social network within each school and begin to start to actually document the transmission of the intervention effects. So, that's one thing, but it's not using, digital media. And I just have to say, because I get asked this question often, and often the question is, do you think you could develop a web app that would produce the same effect? These interventions are group-based and they're very therapeutic in nature. And they borrow a lot from the field of clinical psychology and psychiatry, where we're essentially delivering it's briefer, but an intervention for someone who suffers from depression, but we're delivering it earlier on to a youth who has a more pessimistic, hopeless profile, who it doesn't necessarily suffer from severe depression. So these are therapeutic. There's something to a group process as well. The training procedure for the facilitators is quite intensive. So I'm not sure if you could get the same effect through an individual interacting with a computer no matter how wonderful the website looks. And I'm also not confident yet, but I'd be willing to be convinced otherwise, but I'm not confident that a young person without all of this knowledge could deliver the intervention with the same level of expertise and professionalism.
Could I maybe just a comment on this as well? I'm curious, Patricia, your thoughts on this. In a sense, the question triggered in me the notion of the bright side or the positive side of social media. But I was thinking also about the darker side, and in relation to impulsivity. And I'm just curious as to whether some of the examples that are emerging now that are actually technology-driven examples of impulsivity, expressions, disinhibition, even bullying through the virtual world that are actually perhaps, it's really more of a question, being facilitated in some sense by that environment. So, the same technology offers wonderful opportunities, but I wonder if it's also facilitating for example, particularly in relation to impulsivity. I'm not sure if...
Yeah, I don't have any data on that. I can only speak to a study that I'd heard, a Canadian study I heard about where even though it's something that's on everyone's mind, the majority of bullying behavior, peer-to-peer victimization, is still in the form of face-to-face, non-digital. Mm-hmm. But it's something to keep an eye on.
As a university administrator, I'm just kind of struck or shocked by, I guess just what certainly on the surface appears very disinhibited, and what would have been 10 years crossing a major line is really... we're being desensitized, and I'm assuming young people as well are. But it was just a thought.
Question back here.
Andrei Krasikov, BC, Vancouver. Fantastic session. Truly enjoyed every single talk. Question about the harm reduction. Marijuana. Right now, we, as a physicians, can prescribe, as you know, marijuana license to our patients. However, with changes in legislation, who is actually produce this marijuana, if I'm prescribing aspirin, I know it's 81 milligram once a day and I know what effect. I do know marijuana helps my patients with the pain control, but I have no idea where he will get right now marijuana, what components are presently in marijuana, and so on and so on. And that's why I believe a lot of physicians are lost right now. We definitely did see in Vancouver fantastic changes with the clean site introduction in 2003. But what we will do with marijuana?
It's a tough question, partly for debate after this session. I would say cannabis harm reduction is in its infancy. Part of this has to do with the sort of the regulatory regime around medical marijuana and street access, and a system that cannot guarantee purity of product when delivered as a therapeutic modality. Having said that, by and large, toxicity and other ill effects are low with cannabis relative to others. So. Absolute harms, probably less concerned than some of the other interventions I talked about. But what a cannabis harm reduction approach might look like, I think, is still open for debate, and could well involve net consideration across decriminalization and legalization.
Franco, you had a comment?
Yeah, the other piece to that is that if you look at the literature in terms of, if we're going to think about harm in relation to cannabis, to marijuana, you think, well, what do we know about cannabis effects? Well, much of the literature is actually grounded, if you think about the cycle of how long it takes for a study to be completed, and then the actual potency of the marijuana has also changed dramatically. So much of the literature actually is grounded in a different time. So even the base effects that we understand about marijuana, because it's such a moving target in terms of potency and some of the new, the new crops that are being created now, and much more potent. So it indirectly relates to your question as well, because in order to understand the harms, you have to understand what the base rate is. And the base rate is not necessarily what the literature will tell you today, because today's marijuana is not the same as 10 years ago.
Question, yep.
Bill Avison from University of Western Ontario. I have a question for Cam, because I think the harm reduction issues are, scientifically, I think we know where we are on this, that they do have an impact. And I thought it was very telling that you mentioned that this is not just a KTE exercise to get this picked up by policymakers. Any thoughts about what steps we would have to take to get more uptake by policymakers?
That's a great question, and I appreciate that you picked up that point, because I really do want to underscore that there are limitations to the way we think about KTE for certain health interventions for certain populations that preclude the usual model. If you agree with that, then we're in a situation of what kinds of interventions are necessary, ranging from the attitudinal all the way to the political dimension of the spectrum, that would influence exchange of knowledge, a good evidence base into routine practice. And this gets to the core of issues around value change and so on. And we've seen this in other addictive behaviors around drunk driving, for instance. You know, the history of drunk driving now, it's unthinkable, whereas when I went to high school, it was just a routine thing. There's cultural and values issues that seep into this. And so I don't think it's a matter of sort of packaging your knowledge exchange activities and hoping for the best when you're talking about a value-laden landscape that includes specific views on the morality of illicit drugs, what people who use illicit drugs are like, and so on. And those things cannot be divorced from the discussion.
Dr. Fantas, you have a question?
Yeah, question. Yeah, George Fantas, University of Toronto. I wanted to ask a question about the new therapies, the vaccines. And I'm not familiar with them, so maybe a naive question, but we heard about predisposition to substance abuse and so on. And there's a common pathway that was outlined for many different of the substances. So I'm wondering, if we do a vaccine, does it have to be multivalent to attach to many different potential drugs? Or if we do one, is that going to be adequate? Do they just switch to another drug?
No, it's a absolutely terrific and very important question. I mean, part of the answer is captured on my last slide, which you'd have to be a super speed reader to pick up on it. But the very last point was polydrug use, which speaks to at least an element of what you're asking. Most drug users are polydrug users. So the current thinking in terms of approaches to vaccine are drug specific. So basically the concept is the drug is the culprit, and in that model. But your point is extremely well taken, that we know in the sense of a common pathway, that these different drugs converge on this common system that over time it gets disrupted. So you're really, in some ways, that approach would suggest you're fighting a bit of an uphill battle where you're chasing each compound down, developing analogs in order to precipitate a specific immune response to that compound. I think the way things stand now, that's the direction things are going. It's actually molecule targeted, so the molecules act as a hapten, if you will. The protein base stabilizes that hapten, so it allows the immune system to recognize it, because most drugs of abuse are quite flexible and molecularly speaking, and for that reason they're not easily detected by the immune system. So there's a long-winded way of saying that the current strategy is drug by drug. Your point's well taken. It would mean vaccinating, and then you have the added challenge of polydrug users. And the last point I'll make is, and it speaks to indirectly to some of the comments that are being made around integration. You know, we've heard of social determinants of health. We have community-based programs that are so disconnected from that kind of approach. We need, if that's a direction that policymakers would be willing to look at, we need to understand, well, if that was to fully express itself, what are the implications for a community-based treatment program? How would that dovetail? If you vaccinate, even if you had a perfect vaccine, vaccinated against cocaine, what are the side effects? What are the polydrug side effects of that? Would there be an elevated use of other drugs? What if you vaccinated against all drugs of abuse? Would there be an increase in gambling and other impulsive behaviors? So it's a big field, and I think the good thing is that this kind of scientific direction, I hope, will precipitate those broader discussions and actually paradoxically in some ways lead to more integration.
Patricia, you had a point?
Just a quick question about that form of treatment. I'm going to show my non-medical background, but will people with compromised immune systems not be able to benefit from those treatments?
Well, I'm just speculating here, but I would imagine that people with compromised immune systems would contribute to the variability in the immune response to that, and they would have, arguably perhaps a weaker response. So that's another good point, right? So if the addiction is proceeded to a point where there is, perhaps as a result of the addiction, a compromised immune system, how? And it speaks also to the stages, when you intervene.
Dr. McDonald?
I just want to, as a vaccinologist, add 2 points. You're talking about the absolute most difficult age group in Canada to reach with any vaccine, period. Done. Lots of experience with that.
I'm just reporting it.
Yeah, young people are incredibly difficult to reach for immunization, but that's not the point I want to make. Okay. I wanted to go back and pick up on a couple of things that were being said by Chief Christian and some of what you said, Patricia, in that maybe we need to go back farther and say, what can we do for families of school-age kids and within the communities where their school-age kids live to try to build that resiliency so that when they move away from the parental piece and the teacher piece, they've actually got better skill sets for healthy living. And I think, yes, it's great to be able to do this in schools, but I know old data, but in the Canada Youth and AIDS study that we did in the late 1980s, these kids start dropping out by grade 7. So the ones you really want to go after that are the highest risk, they're already gone by grade 9. So you need to be back up into grade 3, 4, 5 to be able to do anything to really get the hardcore ones that end up having the major problems. So could you tailor your program not to what you did, but move it back down younger, number one, and could you do it for both families as well as community focused in a quite different way?
I think the answer to that question is that we have to go back to the risk profiles and understand them from a developmental perspective. And these are, they're not personality, they're temperament profiles. They're observable at 3 years of age. And is there any one intervention that will fix the problem? I'm not sure. The interventions we've developed have helped young people at the year 7 or grade 7 or 8 transition into adolescence without taking up substance use as a way to cope with either emotions or their behavioral profile. It gives them an extra 12 months of neural and social development without binge drinking and illicit drug use. And it appears to have long-term benefits for them emotionally, behaviorally. We're looking into the cognitive and the academic outcomes now. But in terms of targeting these kids earlier on, absolutely, because we know they're already struggling much earlier on. And I don't think it's an and/or question. They will probably need, and we know they do need, help transitioning to primary school years, and you need parents to help them with that, and you need teachers to help them with that, and they'll probably need help, we know they need help transitioning to high school and to an autonomous social life, and they probably need help going to university if they ever get there, and that interventions and public health strategies should be thinking about these trajectories as having specific needs, but needs at different developmental milestones.